Welcome to Pediatric Case Review. Today's lecture focuses on Russell-Silver syndrome, a rare genetic growth disorder. We will explore clinical presentations, diagnostic approaches, and evidence-based management strategies. This advanced session targets physicians, geneticists, and pediatric specialists seeking comprehensive understanding of this complex condition. Let's begin our detailed clinical review. Consider this clinical scenario. A 3-year-old child presents with severe short stature, measuring -3 standard deviations below mean height. The child demonstrates relative macrocephaly, prominent forehead, and notable body asymmetry with the left leg shorter than the right. Which clinical scoring system would be most appropriate for diagnosis? The correct answer is A. The Netshine-Harbison clinical scoring system represents the gold standard for Russell-Silver syndrome diagnosis. This system requires 4 out of 6 clinical criteria, including intrauterine growth restriction, postnatal growth failure, relative macrocephaly at birth, protruding forehead, body asymmetry, and feeding difficulties during infancy. A newborn receives clinical diagnosis of Russell-Silver syndrome. The pediatric team orders comprehensive molecular genetic testing to confirm the diagnosis and provide accurate genetic counseling to the family. What represents the most common genetic abnormality identified in patients with Russell-Silver syndrome? Consider the molecular mechanisms involved. The correct answer is B. Loss of methylation at chromosome 11p15.5 imprinting center 1 represents the most frequent genetic abnormality, occurring in 30 to 60% of cases. This hypomethylation affects insulin-like growth factor 2 expression, leading to growth restriction. Maternal uniparental disomy of chromosome 7 accounts for additional cases. Review this prenatal case. Ultrasound at 32 weeks gestation demonstrates fetal growth restriction with asymmetric measurements. At delivery at 39 weeks, birth weight measures 2,100 grams, length 43 centimeters, and head circumference 34 centimeters. Which classification best describes this birth parameter presentation? The correct answer is A. This infant demonstrates small for gestational age status with relative macrocephaly, a hallmark of Russell-Silver syndrome. The weight and length fall below the 3rd percentile, while head circumference remains relatively preserved. This asymmetric growth restriction pattern occurs in over 90% of affected patients. Examine a 2-year-old child with confirmed Russell-Silver syndrome during routine follow-up. The pediatrician performs detailed facial assessment to document dysmorphic features. Among the following options, which facial characteristic represents the most typical finding in patients with Russell-Silver syndrome? Consider the classic phenotypic presentation. The correct answer is B. The triangular facial configuration with prominent forehead and small pointed chin represents the classic craniofacial phenotype. Additional features include downturned mouth corners and thin upper lips. These facial characteristics become more pronounced with age and help differentiate Russell-Silver syndrome from other growth restriction disorders. Consider a 5-year-old child with suspected Russell-Silver syndrome presenting for evaluation. Physical examination reveals apparent leg length discrepancy and subtle facial asymmetry. The physician needs to determine clinical significance. What measurement difference between limbs confirms clinically significant asymmetry for diagnostic purposes in Russell-Silver syndrome? The correct answer is B. Clinically significant asymmetry requires measurement difference greater than 1 centimeter or 5% between limbs. Proper measurement extends from anterior superior iliac spine to medial malleolus. Body asymmetry affects 60 to 70% of patients and may necessitate orthopedic management, including shoe lifts or surgical intervention. Analyze this 3-month-old infant with Russell-Silver syndrome experiencing poor weight gain since birth. The infant demonstrates characteristic feeding pattern with small volume intake, slow feeding pace, frequent regurgitation, and tendency to fall asleep during feeds. What represents the primary underlying mechanism responsible for these feeding difficulties? The correct answer is C. Low appetite related to growth hormone deficiency represents the primary mechanism. Contributing factors include oral motor dysfunction and gastroesophageal reflux disease. Approximately 60 to 70% of infants experience significant feeding difficulties. Management requires high-calorie nutritional supplementation, frequent small-volume feeds, and occasionally gastrostomy tube placement for adequate nutrition. Review growth data for an 8-year-old with Russell-Silver syndrome. Birth weight measured 2,000 grams at term. Current measurements show height of 110 centimeters, representing -3 standard deviations, and weight of 18 kilograms, representing -2.5 standard deviations. Which growth pattern proves most typical without treatment? The correct answer is B. Patients demonstrate persistent short stature with decreased growth velocity. typically 3 to 5 centimeters annually, below normal rates. Without intervention, adult height reaches -2 to -3 standard deviations. Growth hormone therapy significantly impacts outcomes, potentially improving final adult height by 5 to 10 centimeters. Perform comprehensive musculoskeletal examination on a 6-year-old child diagnosed with Russell-Silver syndrome. The physician carefully assesses extremities for characteristic skeletal abnormalities. Among the following skeletal findings, which abnormality represents the most commonly observed manifestation in patients with Russell-Silver syndrome? Consider typical examination findings. The correct answer is A. Clinodactyly of the fifth finger represents the most common skeletal finding, occurring in 40 to 60% of patients. Additional skeletal manifestations include brachydactyly, proportionally small hands and feet, and delayed bone age. These minor skeletal anomalies, while not specific, support clinical diagnosis when present. Russell-Silver syndrome involves complex genomic imprinting defects affecting growth regulation. Understanding the molecular mechanisms requires knowledge of parent-of-origin gene expression patterns. At the chromosome 11p15.5 locus, most commonly affected in Russell-Silver syndrome, which parent's genetic material demonstrates preferential expression. Consider imprinting biology fundamentals. The correct answer is A. Loss of methylation results in increased maternal allele expression at the imprinted locus. Normally, the paternal allele expresses insulin-like growth factor 2. Hypomethylation causes biallelic maternal expression, reducing this crucial growth factor. Notably, Beckwith-Wiedemann syndrome demonstrates the opposite imprinting pattern, causing overgrowth rather than growth restriction. A neonate presents with clinical features highly suggestive of Russell-Silver syndrome, including intrauterine growth restriction, relative macrocephaly, and prominent forehead. The genetics team considers appropriate molecular diagnostic testing to confirm the clinical diagnosis. What represents the first-line genetic test recommended for suspected Russell-Silver syndrome patients? The correct answer is B. Methylation-specific testing for chromosome 11p15.5 and chromosome 7 represents first-line molecular diagnostics. This approach, typically using methylation-specific multiplex ligation-dependent probe amplification, identifies 50 to 60% of cases. Negative results warrant comprehensive genetic evaluation, including copy number, variant analysis, and broader sequencing. Consider this differential diagnosis challenge. A newborn presents with intrauterine growth restriction, triangular facial configuration, and clinodactyly of the fifth fingers. Chest radiography reveals notable rib abnormalities. Which alternative diagnosis requires consideration in the differential diagnosis of this patient presenting with features overlapping Russell-Silver syndrome? The correct answer is B. Freeman syndrome enters differential diagnosis with significant phenotypic overlap, including severe growth restriction and skeletal abnormalities. Distinguishing features include more prominent skeletal dysplasia, normal rather than increased head circumference, and different facial characteristics. Other differentials include Mueller-Breen nonnaism and primordial dwarfism syndromes. Molecular testing provides definitive diagnosis. A 4-month-old infant with Russell-Silver syndrome presents to emergency department with lethargy and jitteriness. Laboratory evaluation reveals blood glucose level of 30 milligrams per deciliter without detectable ketones. What represents the most appropriate immediate management for this infant with symptomatic hypoglycemia? Consider standard pediatric emergency protocols. The correct answer is B. Symptomatic hypoglycemia requires immediate intravenous dextrose administration, typically 0.2 to 0.5 grams per kilogram as 10% dextrose bolus, followed by continuous glucose infusion. Hypoglycemia results from inadequate glycogen stores and increased metabolic demands. Prevention strategies include frequent feeding schedules and avoiding prolonged fasting. Evaluate a 4-year-old child with molecularly confirmed Russell-Silver syndrome. Current height measures -3 standard deviations below mean. Growth velocity measures 3 centimeters per year. The endocrinology team considers growth hormone therapy. Which criterion or criteria support initiation of growth hormone treatment in this patient with Russell-Silver syndrome? The correct answer is D. Growth hormone therapy receives approval for Russell-Silver syndrome independent of documented growth hormone deficiency. Typical treatment criteria include height below -2 to -2.5 standard deviations with confirmed diagnosis. Therapy demonstrates significant efficacy, improving final adult height by approximately 5 to 10 centimeters. A 6-year-old child with Russell-Silver syndrome begins growth hormone therapy after meeting treatment criteria. The pediatric endocrinologist determines appropriate dosing protocol. What represents the recommended starting dose for growth hormone therapy in pediatric patients with Russell-Silver syndrome? Consider standard endocrine treatment guidelines for this indication. The correct answer is B. Recommended dosing ranges from 0.035 to 0.07 milligrams per kilogram daily via subcutaneous injection, preferably administered in the evening. Regular monitoring includes height velocity assessment, insulin-like growth factor 1 levels, and bone age evaluation every 6 to 12 months. Monitor for scoliosis and glucose metabolism changes. Manage an 18-month-old toddler with Russell-Silver syndrome presenting with weight below the first percentile. The child demonstrates significant feeding difficulties, refusing solid foods, and accepting minimal formula volume. Parents express concern about inadequate growth. What represents the most appropriate nutritional intervention for this child with persistent feeding difficulties? The correct answer is B. Optimal management combines high-calorie formula supplementation targeting 120 to 150% of recommended intake with comprehensive feeding therapy. Multidisciplinary approach includes nutritionist consultation, occupational therapy, and speech therapy. Gastrostomy tube placement remains reserved for severe refractory cases failing conservative management strategies. Evaluate a 10-year-old patient with Russell-Silver syndrome demonstrating leg length discrepancy measuring 3 centimeters. The child presents with mild limp without associated pain. The orthopedic team considers management options. What represents the recommended management approach for this degree of leg length discrepancy in a pediatric patient with Russell-Silver syndrome? The correct answer is B. Leg length discrepancy exceeding 2 centimeters warrants shoe lift intervention on the shorter limb. Surgical limb lengthening procedures become consideration for discrepancies greater than 5 centimeters after skeletal maturity. Additional management includes regular scoliosis screening and physical therapy addressing muscle imbalances secondary to asymmetry. During routine follow-up for a 12-year-old patient with Russell-Silver syndrome receiving growth hormone therapy, the endocrinologist considers comprehensive endocrine screening, beyond growth hormone treatment monitoring, which additional endocrine condition requires regular surveillance in patients with Russell-Silver syndrome. Consider common associated endocrine abnormalities in this population. The correct answer is C. Precocious puberty affects approximately 15 to 20% of Russell-Silver syndrome patients. This complication further compromises final adult height potential by accelerating skeletal maturation. Regular monitoring of pubertal development proves essential. Early puberty may necessitate gonadotropin-releasing hormone analog therapy to preserve growth potential. Parents of a 5-year-old child with Russell-Silver syndrome express concerns as their child enters kindergarten. They report difficulty with fine motor tasks such as cutting with scissors and handwriting. The parents seek information regarding expected neurodevelopmental outcomes. What represents the typical neurodevelopmental prognosis for children with Russell-Silver syndrome? The correct answer is B. Most patients demonstrate normal overall intelligence. However, approximately 30 to 40% experience specific learning difficulties. Common challenges include fine motor delays, attention deficits, and speech delays. Early intervention with occupational therapy, speech therapy, and appropriate educational support significantly improves outcomes and functional abilities. An 8-year-old patient with Russell-Silver syndrome receives growth hormone therapy for 2 years with good growth response. The endocrinologist reviews appropriate monitoring protocols for continued treatment. Which metabolic parameter requires regular surveillance during ongoing growth hormone therapy in patients with Russell-Silver syndrome? Consider treatment-related complications. The correct answer is B. Fasting glucose and hemoglobin A1C require regular monitoring because growth hormone therapy can induce insulin resistance. Assessment should occur every 6 to 12 months. Additional monitoring includes insulin-like growth factor 1 levels, bone age advancement, and lipid profiles. Early detection enables intervention before progression to diabetes. Consider long-term outcomes for an adult patient with Russell-Silver syndrome who received growth hormone therapy throughout childhood, beginning at age 5 and continuing until near final height. What represents the expected adult height outcome with appropriate growth hormone treatment compared to untreated individuals? Consider evidence-based treatment efficacy data. The correct answer is B. With growth hormone therapy, adult height typically reaches -1 to -2 standard deviations, representing 5 to 10 centimeter improvement over untreated outcomes. Treatment duration, starting age, and compliance significantly influence results. Overall prognosis remains favorable with appropriate multidisciplinary management throughout childhood and adolescence. Thank you for joining this comprehensive review of Russell-Silver syndrome. We covered diagnostic criteria, molecular genetics, clinical management, and long-term outcomes. Please subscribe to Pediatric Case Review for additional expert clinical lectures. Share your questions or suggest future topics in the comments section. Your engagement helps create valuable educational content for medical professionals worldwide.